Thank you very much for the kind introduction. Dear colleagues, good morning. This follows my talk of yesterday where I was touching in general medical therapy of renal colic, and now we are going into medical expulsive therapy and have a review of that. As I was alluding to yesterday, unilateral obstruction of a urinary tract causes terrible pain because of the abrupt distension of renal capsule and pelvis, as well as the ureter proximally of the stone. And there is, of course, hyperperistalsis of the obstructed ureter. We are going to have a look into that. And there are prominent hemodynamic changes. I'm not going to touch that this morning. Now, hyperperistalsis. The treatment of renal colic has two goals, as I was alluding to yesterday. Proximally from the stone, we desire, if the stone gets stuck, that the pacemaker activity would be reduced in order to reduce pain. Once the stone starts to move, we would like to have more pacemaker activity in order to have a stone expulsion facilitated. At or distally from the stone, and that's where medical expulsive therapy starts, we would like to have a dilatation, relaxation of the ureter for a facilitation of the stone passage. I was showing yesterday this large list of treatments that have been tried over the years in treating renal colic. And this morning I'm going to spasmolytics, alpha blockers, calcium channel blockers, as well as steroids. As I was showing yesterday, there are modulators of ureteral peristalsis, and the contraction is, among others, brought about by alpha-1 receptors. And it's known from research over the years that the more distal you get, the more abundant alpha-1 receptors become in the ureter. So medical expulsive therapy is all about relaxing the ureter, mainly by blocking the alpha receptors. And there was quite some enthusiasm, let's dilate this ureter, and there are many successful, more or less controlled studies over the years. In 2006, Hollingworth and co-authors put together a meta-analysis of 9 controlled studies that they were able to find between 1981 and 2005. There were at that time no double-blind trials. The majority of stone situation studies were stones larger than 5 millimeters, and they were comparing in this analysis the alpha blockers. It was mainly tamsulosin in 4 out of 5 studies versus the calcium channel blocker nifedipine. And you look at the left, the risk ratio, so-called risk ratio for spontaneous stone passage was significantly higher with nifedipine, 50% more chance of passing spontaneous stone versus controls with placebo. Exactly the same with alpha blockers, mainly tamsulosin, a 50% increase in the chance of having a spontaneous stone passage. Now there came some frustration on our way when the first, I'm proud to say that, Swiss study, the first randomized double-blind placebo-controlled trial in distal ureteral stones in 90 patients, stones up to 7 millimeters in diameter. All patients got diclofenac and metamizole on demand, plus either tamsulosin or placebo. The primary endpoint, controlled by CT scan, was stone expulsion after 21 days. This happened in placebo-treated patients in 89% and in tamsulosin-treated patients in 87%. This was a not significant difference. There were secondary endpoints, however. The median time for stone passage in days was somewhat lower in tamsulosin, but it was not statistically significant. But what was statistically significant, the number of additional analgesic treatment in patients was clearly lower with tamsulosin, so there was a better pain control with the alpha blocker. A year later appeared a very large study, 3,200 Chinese patients, prospectively randomized, 18 till 50 years old, with distal ureteral stones 4 to 7 millimeters in diameter, diclofenac on demand. They compared nifedipine versus tamsulosin. And as you see, the expulsion after 4 weeks was significant. Oh, I'm sorry. was significantly better with tamsulosin, was statistically significant. The expulsion time with tamsulosin was about half of the one with nifedipine, and the additional doses of diclofenac were also about half with the tamsulosin. So the conclusion was that tamsulosin was significantly better than nifedipine, also with regard to adverse effects of the drug. Now, there is a very recent study published in Urological Research, again from China, and they were focusing on immediately prevesical intramural stones. And the background is that, as you know, the most relevant blockage of spontaneous stone passage occurs in the intramural part or the segment of the ureter, which is the narrowest one. And once the stone is impacted there, you get vesical irritability, which is very unpleasant for the patient, and the question arises whether antimuscarinics would have a role here. And as you know, in the urinary tract, there are various alpha receptor subtypes. Alpha-1A receptor is mostly abundant in proximal urethra, prostate, and bladder. The alpha-1B receptor, mainly in the vascular smooth muscle cells. And the most important for our purposes is the alpha-1D receptor, which is most prevalent in the distal intramural ureter. So this may be the most promising target for medical expulsive therapy. Now, the alpha-1 receptor blocker tamsulosin is selective for alpha-1A as well as D to about the same extent. There is another one, naftopidil, is threefold higher selectivity for alpha-1D than alpha-1A receptors. So they were selecting this one to study, and they did a study in 76 patients with intramural urethral stones, and they randomized them into 3 groups, giving naftopidil once a day, or in group B, naftopidil plus tolterodine, an antimuscarinic twice a day, or in group C, only the antimuscarinic. And what you see here is on the left, the expulsion rate after 2 weeks was highest when the naftopidil was present, whether it was without or with the tolterodine. So it was significantly better. The pain after 3 days, however, was best controlled when the antimuscarinic was present. With the naftopidil alone, there was clearly more pain. And the urgency of the patient, which is very unpleasant for his quality of life after 3 days, was significantly better with the antimuscarinic when the antimuscarinic was present. Now, so far, because of the abundance of the alpha receptors in the distal ureter, most studies have been done in distal urethral stones. However, it can also be used in proximal stones. This study by the group of Kemal Sarika came out in 2010. They did an analgesic versus analgesic plus tamsulosin in 92 Turkish patients with proximal urethral stones up to 1 centimeter diameter. And you see the expulsion rate after 4 weeks was significantly better with the tamsulosin. Expulsion time significantly shorter with tamsulosin, and the pain score was also significantly lower with tamsulosin. Now, most recently, another Turkish study was looking at 79 Turkish patients having ESWL with an acute renal colic with hydration versus a pre-treatment with another alpha blocker, doxazosine, before ESWL and then for 14 days after the treatment. Both groups got diclofenac on demand. There were upper urethral stones larger than 5 millimeters in diameter, and the follow-up was at 14 days by a KUB, and the stone-free rate was clearly higher with the alpha blocker, as shown here. There was almost no additional URS necessary, only 5% versus 70% with just hydration. No Steinstrasse with the alpha blocker. However, pain was not controlled to a larger extent with the alpha blocker versus non-alpha blocker. Now, the story of the steroids, which I call an Italian fairy tale, probably. The rationale behind it is an anti-edema agent. There are no studies with a single therapy with steroid, only combinations. That's why it is hard to disentangle sometimes the effects of the steroids of other agents that have been given. This study from Borghi, which is widely quoted from 1994, compared methylprednisolone plus nifedipine versus prednisolone and placebo. And it was showing that methylprednisolone plus nifedipine was better with regard to the expulsion after 45 days. So my conclusion would be nifedipine is better than placebo, but it doesn't say anything about the effect of steroids. There is the more popular and more recent study by Porpiglia from 2006, deflazacort plus tamsulosin versus tamsulosin alone. And of course then, with the deflazacort, the expulsion after 10 days was significantly better. So here you have some additional effect of the steroid. So I come to my conclusion, what would be my suggested treatment for acute renal colic? As I was alluding to yesterday, no forced hydration. The first I would give is non-steroidal anti-inflammatory drug, mandatory if not contraindicated intravenously or orally. I think the alpha blocker these days is more or less mandatory in all kinds of stones, whether they are distal or proximal. The question may be asked for intramural stones, antimuscarinic may have some effect, a steroid, question mark. Then I would add as the next step a non-opioid. Paracetamol did quite well in the studies that I was quoting yesterday, as well as Novamine sulfone can be given. And the last step would be an opioid. I remind you, no pethidine for regular treatment more than 24 to 48 hours because of the danger of addiction. And with that, I thank you for your attention.